CPR on a baby using adult technique can crack ribs or fail entirely. Hand placement and compression depth change dramatically from neonates to adults, and most people cannot tell the difference. It all starts with where on the chest you press. For an adult, the baseline technique begins with correct positioning on the lower half of the breastbone. Place the heel of one hand directly on the center of the chest, then stack your second hand on top, interlocking your fingers to keep force concentrated on the sternum. Position your shoulders directly over your hands to deliver straight downward pressure. If you are the sole responder, call emergency services immediately before starting compressions. As soon as an automated external defibrillator, or AED, is available, bring it into the response sequence. Turn the device on, apply the standard adult pads to the bare chest, and let the AED analyze the heart rhythm. Follow the voice prompts exactly and return to chest compressions immediately when directed by the device. Neonatal CPR follows a separate protocol distinct from older infant care. For a newborn, wrap both hands around the chest and place both thumbs side by side on the lower third of the breastbone. For an infant under 1 year, a single rescuer uses 2 fingers placed on the center of the chest just below the nipple line. If a second rescuer is present, transition to the 2-thumb encircling technique. For children, use the center of the chest, applying pressure with either one hand or 2, depending on the child's size. When applying an automated external defibrillator, pediatric pads are the preferred option for younger or smaller patients. If only adult pads are available, use them as a fallback, but place one on the front of the chest and the other on the back to ensure they do not touch or overlap. To perform effective adult compressions, apply enough downward force to depress the breastbone between 5 and 6 centimeters. This target is equal to 2 to 2.4 inches of depth. Compressing too shallowly fails to pump enough blood to the brain, while pushing too deep increases the risk of severe internal injuries. Equal focus must be placed on the release. After each downward stroke, allow the chest wall to return fully to its natural position. This is known as complete chest recoil. Rescuers often make the mistake of resting their hands on the sternum between compressions. Leaning on the chest prevents the heart from refilling with blood, which drastically reduces the quality of CPR and lowers the rate of survival. Controlled rhythmic force is the standard. For the smallest patients, compression depth scales directly to the physical size of the chest, following a strict 1/3 rule. For a newborn neonate, compressions must depress the chest by 1/3 of its total front-to-back depth. This translates to a precise range of 1.5 to 2 centimeters, or roughly 1/2 to 3/4 of an inch. Pushing beyond this narrow threshold risks damaging highly fragile internal thoracic structures. Moving up to infants under 1 year of age, the core principle remains 1/3 of the chest depth, but the physical distance increases. An infant requires a compression depth of approximately 4 centimeters, which equals 1.5 inches. For children from age 1 up to puberty, the 1/3 standard continues, but the manual force must scale up to reach a deeper target. A child's chest requires a depth of approximately 5 centimeters, or 2 inches. This size-based progression ensures that the mechanical force applied matches the skeletal development of the patient. For adults, children, and infants, chest compressions must maintain a steady pace of 100 to 120 beats per minute. When performing CPR alone, use a ratio of 30 compressions to 2 breaths across all 3 age groups. If a second rescuer joins, the ratio for children and infants changes to 15 compressions to 2 breaths, while the adult ratio remains 30 compressions to 2 breaths. To prevent fatigue, active rescuers must switch roles every 2 minutes. If you cannot give rescue breaths during an adult's sudden collapse, continuous hands-only CPR is highly effective. However, because cardiac arrest in children and infants usually stems from respiratory issues, ventilations are vital. For newborn neonates, resuscitation begins with ventilation support before starting compressions, following a tight ratio of 3 compressions to 1 breath. To open any patient's airway, use a gentle head tilt, chin lift, but switch to a jaw thrust maneuver if a spinal injury is suspected. Across all age groups, critical errors can ruin these life-saving efforts. Avoid placing hands too low, compressing directly on the ribs, delivering shallow pressure, or over-ventilating the lungs. Because precise technique is vital, this guide does not replace hands-on practice. Enroll in formal CPR and neonatal resuscitation courses to master these protocols. Precision saves lives. Remembering these distinct depths and placements turns panic into decisive, life-saving action when seconds matter most. Share this guide to help save a life.